Hello everyone, my name is Karan. I'm one of the Echo Fellows at St. Mike's, and today I'm going to be giving you a talk on M mode. And the title of my talk is Throwback Thursday, M mode. So what we'll be going through over the next 30 to 40 minutes is what is M mode, why is it still relevant, and I wanted to review some classic valvular, myocardial, and pericardial M mode findings. And really, M mode goes back to the 1950s. The original description was by Dr. Ing Edler. He was a Swedish cardiologist who described M mode in 1953. And he worked primarily with Carl Helmuth Hertz. And Hertz, you may recognize the last name. It's quite a famous last name in the physics world. He is a German physicist. His father was awarded the Nobel Prize for Physics, and his great uncle was Heinrich Hertz, who was the individual who first conclusively proved the existence of electromagnetic waves, and the Hertz unit is named after that. So some pretty historic names involved in the early work for M mode. And really, the only reason I bring this up is that it is really the foundation of the subsequent ultrasound and echo technology that we use today, 2D, 3D, etc. So this is kind of the core principles, and that's when it was started. This is one of the principal articles in relation to M mode. This came out in 2010 by Dr. Feigenbaum. And it's a lot of this presentation is based on this article, as well as some other resources. But I wanted to bring this up because A, it's a good read for anyone who's interested in M mode and in echo. And B, I really like these two lines from the abstract. First, Dr. Feigenbaum says that M mode is considered to be obsolete by many, which is true, and especially the C1s and C2s going through and learning the scan will realize how often we just kind of flip through M mode. We don't really critically examine it too much in most cases. But I also really agree with this other line where Dr. Feigenbaum says that in certain scenarios, M mode can be very helpful to making an accurate and complete echocardiographic assessment. And that's my goal for today, is to convince you that M mode is still relevant and that old can sometimes be gold. Okay, so what is M mode? So M mode, to understand that first we have to go back a few steps and understand what A mode, B mode, A mode and B mode are as well. So A mode, as you may recall from the talk a few weeks ago, A stands for amplitude. And what this is a display of processed information from the receiver versus time, and the speed of sound equates to depth. B mode then converts that A mode information into brightness modulated dots, B standing for brightness. And M mode then goes one step further, M standing for motion, and uses B mode information to display the echoes from a moving organ. And you can kind of get a sense of that in the cartoon on the right, where M mode really looks at a particular structure in one imaging plane over time. And why that's relevant is that it gives you very high temporal resolution compared to 2D and 3D, and I'll mention that probably a couple more times during this talk. And it's really impressive in terms of how much higher the temporal resolution is. You can have 1 to 2,000 frames per second in M mode versus 30 to 100 frames per second in 2D. And that is truly one of the biggest advantages of M mode, and also why it's relevant today. And so that high temporal resolution can give you complementary information to your 2D, Doppler, and 3D assessment. Combine that, and also there's something to be said about the historical importance as well. Disadvantages of M mode, and obviously the reason why it's gone out of favor and not used in even many labs in North America, is that it's a single dimension. It's off angle and non-perpendicular orientation, and so you really need 2D guidance to make sure you're imaging in a perpendicular plane as opposed to an off-axis or off-angle plane, and that may be giving you erroneous measurements. So where do we measure? So typically we do an M mode through the aortic valve, through the mitral valve, as well as through the LV cavity in your peristernal long axis. And again, you have to be careful that you're imaging on axis, because if you are off, you can get, or measuring obliquely, you can get a significant overestimation of your measurements, such as a LV cavity size, for example. So you really want to make sure you're not imaging through A, but rather through example B, because that's what we would truly want to measure. So to know what pathology looks like in M mode, we first have to have an understanding of what normal is. So this is a normal M mode through the aortic valve. And this is, again, taken from the peristernal long axis. So as you can see, you have the anterior wall of the aorta, you have the aortic valve itself, and you can see the RCC and the non-coronary cusp. And you can see then the posterior wall of the aorta, and you can then see the LA towards the bottom of your screen. In diastole, the aortic valve is closed, and in systole, it opens up. And again, and diastole closes again. And a few characteristics of normal to make a note of in the aortic valve M mode would be a central cusp closure line in relation to the aortic root during diastole, so looking to see that central. Parallel leaflet opening during systole. And you want to actually see a nice, wide, clear separation of your two cusps, indicating that the aortic valve is nice, compliant, free moving. And this is a more real-time visualization of this. And so contrast that to normal to this, which is an example of aortic stenosis. And here you can see that the leaflets are thickened and calcified, and you also see reduced cusp separation in both of these pictures. So kind of classic for aortic stenosis on your M mode. Okay, moving on to your mitral valve M mode. And this is really where you get the highest bang for your buck in terms of M mode. I can see a lot of nice pathology with this in a few cases, but again, first we have to understand normal and what the waves and what the M mode represents. So this is the anterior mitral valve leaflet. And I'll start off with the A wave, which represents atrial contraction. Your C wave represents mitral valve closure, so you can think of it as A for contraction, C for closure. Then you go back to the beginning of diastole, and your D wave represents mitral valve opening. Subsequently, you have your E wave, which is your maximal opening during early rapid filling. And then you have your F wave, which is or F point, which is your onset of diastasis. Again, fairly straightforward. You can think of your E and A waves as very similar to your mitral Doppler inflow patterns. Again, D and C are kind of intuitive as well, with the onset of diastole in the opening of the mitral valve leaflets, and C being the end and the closure of the mitral valve leaflets, and then F is your onset of diastasis. So again, these are just examples of normal, so you can see all those waves I mentioned quite clearly. Mitral valve opening, your E point, your E wave, your A wave, onset of diastasis here at F, and then your closure of your mitral valves. And moving on to your LVM mode. So again, this is taken in peristernal long axis, just below the mitral valve, and you don't want to get the mitral valve leaflet tips in here. You want it to be just the LV cavity. And again, you can see the LV end diastolic dimension, LV end systolic dimension quite clearly. So your RV, your interventricular septum, and your posterior wall as well. Sometimes you can get some chordae that can confuse you as to the delineation between your LV cavity and your posterior wall, but most times it's fairly clear. The other thing to take notes on is you can see an effusion here posteriorly as well. Okay, so we're just going to go through a number of cases because really cases is the best way to understand M mode and the pathology. So the first case is that of a dilated cardiomyopathy, and so the pertinent finding here is really increased E-point septal separation. Remember, that's the definition. So the definition of that is the minimal separation between the E-point and of the anterior leaflet and the septum. Remember, the E-point is the maximum early rapid filling, and anything more than 10 millimeters is abnormal. And really what that is a reflection of the decreased transmitral stroke volume. So very simplistically, I think of it as less forward flow, not a lot of blood to push those leaflets wide open. So you have a increased E-point septal separation here. And keep in mind, this is not valid if there is coexisting valvular disease. Okay, case 2. So this is a really nice example of systolic anterior motion of the anterior mitral valve leaflet, and you can see that really clearly there. I think this is actually a very useful tool of M mode. Sometimes it can be tricky to visualize it and see it clearly on 2D, and M mode can actually be helpful in visualizing that SAM a little bit more clearly and give you a little bit more confidence in making that call when you're reading. This is just another example of the same pathology, SAM. You can see clearly in systole that mitral valve leaflet should stay flat and closed, yet it is coming back towards the septum. And for most systole, you can see that anterior motion. And you can see that in this case and the previous case as well, that in severe SAM, you could actually have the anterior leaflet that touches the septum, and that's very simply known as a SAM septal contact. And again, you can see that right here. This is mostly for historical significance, so I won't dwell too much on this, but this is work from the 80s that looks at SAM septal contact, and you can actually calculate the gradient, the LVOT gradient, using SAM septal contact. And what you do is you measure X and Y here, and X is the duration of SAM septal contact, and Y being the time from the onset of systole to the onset of SAM septal contact. And you can use that to measure the gradient. And it actually correlates fairly well to invasive gradient measurements. So this is, as I did, I plugged into the formula, 25x plus 26 equals the gradient. And it's just a ratio of X and Y. And I thought it was interesting, A, because I never realized you could do that when I was preparing for this talk, but B, also there's some interesting names on this paper. So Dr. Rakowski was one of our U of T, Toronto General echocardiographers, and of course Dr. Weigel, who is quite a famous name locally, and the prestigious Weigel Award is named after him. Again, this is really not something we do on a regular common basis, but just as kind of an interesting point to note. You can also look at the aortic valve for HCM and look to see if there's any pathologies. And the one finding that you can actually see is that you can see the dynamic obstruction. What happens is you can have early closure of the aortic valve in mid-systole. And then as you see here, you could see the fluttering in mid to late systole, and that's from all the turbulent flow and obstruction that is happening in the LVOT. So next case, and I included a normal up top for reference as well, but what you see here quite nicely, and again, I think this is one of the other nice uses of M mode, is that you can see bileaflet mitral valve prolapse here. And here's another example as well with the arrow sign kind of indicating that, and here you can see that here. That's your bileaflet mitral valve prolapse. And if you would, you could see that you can make it out a little bit more clearly. And here's that line. You can see you have to measure it, but you can kind of get a sense that it's probably more than 2 millimeters. In this case, it is clearly more than 2 millimeters of prolapse from the annular plane. And so just some more examples of mitral valve prolapse. So on the left here is a nice example of late systolic prolapse. Mitral valve leaflets look closed for the first half of systole. And then as you can see, they prolapse in the second half. The picture on the right is evidence of hollow systolic prolapse. And again, I think the high temporal resolution of M mode allows for definition of the prolapse and particularly the duration. You can see that often a little bit more clearly with that mode. Okay, so this next case is a nice example of mitral stenosis. And the pertinent findings here are that you can see a reduced EF slope. So rather than a tapering from your E wave down to your F point, what you see here is a flat slope. And as you can imagine, the flatter the slope, the more severe the mitral stenosis. And here what you can actually see is the posterior leaflet interestingly moves anteriorly during diastole. And that's just because of the leaflet calcification, commissural fusion, and diastolic doming that we often see in the mitral valve posterior leaflet on 2D echo. The last thing that you can see commonly is a loss of the A wave, and that's for a couple reasons. One is that the atrial pressure is often quite high, so the atrial contraction doesn't really change the relative LA pressure in relation to the LV pressure. That's why, that's one. And then the other thing is obviously AFib is very common in patients with mitral stenosis. So you may just be an AFib and have lost your organized atrial contraction. Next here we have an M mode at the mitral valve, and this is depicting aortic regurgitation. And the key findings here are severalfold, but one of the main ones is early closure of the mitral valve due to a rapid increase in your LV diastolic pressure. So you have that big jet of AI coming in, your LV pressure rises dramatically and causes your mitral valve to slam shut. And you can see that as a rapid taper from your E point to your F point on the M mode. And this is a nice picture, and what you see here is you can see here that the jet is reverberating against the anterior mitral valve leaflet. See that with the arrows pointing to that. And this is a nice example of an M mode depiction of your classic Austin Flint murmur. So this is a M mode at the aortic valve. And here what you can see, you have a off-center closure line. So normally your closure line should be in the center, and here it's it's quite eccentric. You still have nice opening. You don't have very thickened leaflets. So what this likely represents is a bicuspid aortic valve without aortic stenosis. So no significant stenosis here. And this is just a more contemporary or a more classic picture of that, again, seeing the off-center closure line. This valve also probably is not stenosed, given that it's not particularly calcified and opens quite well still. Okay, so case 7, in that same kind of line of thought, here is a bit trickier, but what we're seeing here is, again, an M mode of the aortic valve. And what we're seeing is gradual tapering and closure of the aortic valve through systole, and still have early closure of the aortic valve. And what this suggests is decreased output or decreased forward flow. Again, remember, normally the aortic valve will remain open throughout systole, but when you have low cardiac output, the valve will taper close before the end of systole. And that kind of makes sense because you have constantly decreasing flow. Let's say your LV is too weak to maintain a constant flow with significant LV dysfunction, or you have severe mitral regurgitating lesion or something like that. And this is just another example. They actually measured it out here. You can see at the beginning, the opening is around 1.9 centimeters, and towards the end is 1.3 centimeters. And remember, normal, that should be very similar throughout the entire systole, the entire opening. So this is a great case, and I chose a subtle one on purpose for the first one, and then I'm going to give you a more classic finding on the right here. And what this is the W sign, I think it was the flying W sign, and this is an indication of pulmonary hypertension. And this is an M mode of your pulmonic valve. Can be in your long axis, but typically in your short axis. And what's happening here? So this is sort of say normal pulmonic M mode finding. So remember, your pulmonic valve is opening away from the transducer. So that's why it looks a little bit unusual or kind of different than you may have seen the mitral and aortic valves. And here you have RV and PA tracings as well for correlation. And what happens is in pulmonary hypertension, obviously your PA pressures are quite high, so you lose your A wave. And that's because atrial contraction doesn't really change the gradient in your RV to PA pressure. And then you see this W sign. And what that is that's a reflective wave coming back from your pulmonary vasculature because your PVR is so high. Contrast that to the far right, which is a M mode and pressure tracings of pulmonic stenosis. And what you see there is actually a prominent A wave, which is reflective of the fact that the RV compliance is reduced, and the RA contraction will have a disproportionately elevated effect on changing the RV pressure. So you actually see a prominent A wave in the far right in the setting of pulmonic stenosis. Okay, next case. So here, this is another kind of classic M mode finding that you may come across, and this is a M mode of elevated LV-EDP, typically in diastolic dysfunction. So what you can see here is you have your E point, your A point, and then before your C point, you have a little bump, and that's called a B bump. And that's what is showing a B bump in the setting of elevated LV-EDP. And what happens is when there's an elevated LV-EDP as a result, the LA contracts against a stiff or already fully dilated or full LV. And you get this rapid increase in the LV pressure to a point that it exceeds the LA pressure earlier than normal. And what happens is that early reversal in the pressures then causes the peak of the mitral valve A wave to be earlier. That causes a more prolonged closure of the mitral valve before ventricular contraction can start. And that prolonged period or plateau period often has interruptions. And that interruption is what we see in the M mode called a B bump or a notch or a shoulder. And that's typically right here between your A and C points of the mitral valve mode. Now, this is a kind of a straightforward case, and basically just looking, basically showing you the absence of an A wave and the setting of AFib. And actually can be useful. Sometimes, you're only getting often 2 or 3 cardiac cycles, and so if you're trying to determine the rhythm, it can be helpful just to look quickly at either your inflows or your Doppler or your M mode, and you can see that there's lots of irregular atrial activity and lots of A wave. Okay, hopefully you're still with me. Case 11. So this is a nice example of constriction. So as you can see, when you inspire, there is a leftward shift of the interventricular septum, so leftward being downward, and because the RV is filling more at the expense of the LV. You can also see quite nicely is diastolic flattening of the posterior wall, and that's because of that constrained posterior wall from the calcified pericardium. So you can see that as well down here. Of the same lines, M-mode can be useful in cardiac tamponade cases. I actually think this is fairly useful, and I've used this before myself personally a few times. And what you can see is the effusion, but also it can be helpful sometimes if you're looking for RV diastolic collapse, like you can see here on the right, which is quite nice and quite clear, especially when it's not as clear in your 2D images. Again, the temporal resolution of M-mode can be helpful for that. Finally, you can see subvalvular aortic stenosis as well. And this can look very similar to a dynamic obstruction where you have early closure of the aortic valve in your M-mode. And the one key is that the closure with a fixed subvalvular obstruction is typically earlier than in your dynamic obstruction, usually in early systole, whereas the dynamic obstruction is usually in mid-systole. So that's one of the differences in the way you can differentiate that. And again, this can just be a clue, especially in the beginning of your scan. If you see this, it may put your spidey senses up to pay closer attention to this in your subsequent 2D images. So in terms of the aortic pathology, this is what you can see. So you can look for aortic stenosis. You can look for dynamic obstruction or fixed obstruction. I don't particularly think those are very useful except for dynamic obstruction and looking for systolic anterior motion. I think that's interesting, but that you would obviously see in your mitral valve mode. It can be useful for looking for an eccentric AV closure line in the setting of bicuspid aortic valve. And the other thing to keep in mind is early closure and a tapered closure in setting of decreased stroke volume. And that's really all I wanted to go through for this talk. This is the summary or takeaway slide that if you didn't pay attention, this is the go-to what I think is the most relevant findings or most relevant conditions for M-mode. I do think that M-mode has a role. I think that the excellent temporal resolution allows us to look at certain aspects of our interrogation or echo a little bit more closely and support our diagnoses a little bit better. And particularly in the mitral valve, looking for systolic anterior motion or for mitral valve prolapse, I think both of those are quite useful. I think it can be useful to look for an eccentric or off-center closure line that can clue you into a bicuspid aortic valve. The pulmonic valve can also add ancillary information in terms of that W sign that I mentioned, and that can be helpful in certain scenarios where you may have insufficient TR jet, for example, and give you another clue. And finally, in terms of your LV M mode, I've used this personally, and I'm sure many of my fellow colleagues have as well, in looking at the LVM mode for constriction or tamponade, particularly when you're looking for chamber collapse when it's a little bit more subtle, or looking for evidence of interventricular dependence and constriction. And finally, looking at increased E-point septal separation in the setting of low output states. And that's really it. Feel free to contact me if you have any questions, and hope you enjoyed the talk. Thanks.